So, hello everybody. My name is Tanya Henshaw and I'm a clinical nurse specialist from Guy's and St Thomas's Hospital in London. And within Guy's and St Thomas's, I work in St John's Institute of Dermatology. So it all gets very complicated. So St John's Institute of Dermatology, within Guy's and St Thomas's, known as GSTT, because we like to shorten things, don't we? So no one quite understands what's going on. So that's me. And I'm going to talk to you today about my experience of setting up a nurse biopsy course. Can I just have a quick straw poll of anybody who already does surgery? Put your hand up. So we've got a few, brilliant. How many of you would like to do surgery? Even better. And how many of you think would benefit your particular service that you're working in at the moment if you did surgery? Yeah. It's a no-brainer, isn't it, for us nurses? Right, so this is St Thomas's. That brings back memories, Erin, do you think, yeah? So we're right in the centre of London, so you can see, so there's the Houses of Parliament there, so we're right opposite Westminster, so in the middle of things, and we're a big tertiary teaching hospital with a very diverse population surrounding us, and we're connected to King's University. So that's our pretty view. So this is kind of loosely called a workshop. I think it was impossible for me to kind of teach everyone practically how to do minor surgery. So we kind of split it up into two. So we're going to talk about me setting up the course, the journey, and then we'll be a kind of bit of a practical demonstration. What I'd like you to do, if there's anything in particular you want me to focus on with the practicality bits, I've got a couple of my own bugbears which I'll cover, but if there's anything that you want me to particularly focus on, let me know at the end and then I'll focus on that, because I think you've all seen a punch biopsy, you've all seen an interrupted suture, so I don't want to teach you how to suck eggs at the end of the day, so I want it to be useful for you. So it would be very remiss of me to talk about biopsy in the UK without mentioning Jill Godsall. And Jill was a nurse at Nottingham Queen's Hospital, and she's now got an OBE for her work in nurse biopsy. And she's the first nurse that I'm aware of in the UK who started doing biopsies on patients. And she had to kind of prove the case that by allowing a nurse to learn how to do biopsies, they could dramatically reduce the waiting times for their patients in their area. And she proved that, and that's what actually happened. So, and she's very well written, she's got lots of articles out there, so look up Jill Godsall if you want to know about the history a bit more. And she'd been doing surgery from 1999, and the course started in 2002, because she wanted to spread the word, and so do I. I was very lucky to do Jill's course several years later, so I knew exactly how it worked then, which was brilliant. At the end of that, there was a name called Preet Kaur. She's one of the nurses that came over with me from the UK. Actually, there are 6 nurses that are over altogether, and I've discovered today, out of the 6, 5 of us do minor surgery or have done minor surgery or are qualified to do minor surgery. So that's just out of the 6 of us. So I think that's really important. And as far as I'm concerned, no one does it better than a nurse, because we are the complete package at the end of the day. I can step into that theatre space and there is nothing in there that I can't do, from stocking up, from maintaining all the machinery, from knowing what all the instruments are, from looking after the patients from beginning to end. So from tail to nose, I know exactly every single job in that theatre space. I don't think doctors do that so much. Anyone disagree with me on that? So, I think nurses are very well placed. We have that holistic view about patients. We can have a petrified patient coming into our room, and by the end of the session, I've managed to relax them. I've cut out the nasty thing. As far as I'm concerned, we've got beautiful everted edges, so for me, that's a nice sign. And it's very satisfying to take a patient through that experience, because patients always remember surgery, especially in the UK. I think perhaps out here there's so much kind of skin cancer, and people are more used to having minor surgery through the GP and what have you. So it might not be so much of a big deal, but correct me if I'm wrong. But in the UK, it's always a big thing. There's kind of life before the biopsy and life after the biopsy. And it's a big thing for patients. It's every day for us. And the experience they have with that minor surgery will dictate how they react to any further surgery in the future. And as we all know, once you've had one BCC or any type of skin cancer, the likelihood of you having another is increased. So these patients are more likely to have surgery in the future. And there's nothing worse than a patient having a really bad experience. And my mother was this patient. I noticed a lovely BCC behind her ear. I said, right, you need to get that cut out. She went to a local consultant who whacked in the anaesthetic as fast as he possibly could. He pretty much had to kind of peel her off the ceiling. And when I spotted several other BCCs 18 months later, she said, no, I'm not having them treated. That's it. No, they can stay there. I don't care. So I had to persuade her to come to St. John's, where I worked, for me to do her biopsies and to have Mohs in our micrographic surgery department there. So it really makes a big difference to these patients. So for me, I'd been working in the derm surgery and laser unit for about 4 years. And during there, I was assisting with Mohs micrographic surgery with complex wounds, flaps, rotations. You're seeing all the new fellows come through the department, and you get a really good feel for who's good, who's not so good, who are naturals at surgery, who are not so natural at surgery. And there is an artistic element to surgery, and not everybody's got it. So I was observing all these lists day out and day in, and then one of our surgical nurses, we had one nurse who was doing minor biopsies. It was nothing particularly official, it was just in the derm surgery and laser unit, and she had very good friends with one of the consultants, and she said, I want to expand my role, I want to make things a bit more interesting, and he agreed to teach her. So that's how it kind of started. So she kind of broke the seal within St. John's Institute of Dermatology. And luckily for me, she went on maternity leave, and they said, well, who wants to do it? So I jumped at the chance to take over her role. So 6 weeks before she left, I then started working with her in her biopsy list, and we went through all the procedures. And so by the time she left, I was pretty confident. And I wouldn't have been confident if I hadn't had that 4 years prior to that, watching surgery day in and day out. It's pretty quick going from biopsy to excision in 6 weeks. So it's absolutely vital, I think, for nurses to have that experience in surgery. Now, Emma, my predecessor, she did have a kind of training pack together, but it wasn't ratified by the hospital, so it wasn't accredited, but she was working towards that. And so I started off taking over her biopsy list, and 8 years later, I had 5 lists. I was an integral part of the skin cancer screening clinic. And in the UK, all patients with a suspected skin cancer have to be seen within 2 weeks and then treated, I think it was in 30 or 60 days completely. So there's a big push and there's a lot of pressure. And that pressure builds, obviously, during the summertime when people start seeing bits of their body they haven't seen for several months. Or there'll be an article in the newspaper about melanoma, and then suddenly everyone panics and goes to their GP. So it kind of peaks and troughs throughout the year. I was working in outpatients departments. I was teaching new registrars, because these poor registrars, it's see one, do one, teach one, and they're completely abandoned out there. Well, they are in the UK. I'm not quite sure what it's like over here. But it's very scary for them, and so I knew they needed a bit of support. And eventually, I ended up setting up the nurse biopsy course, literally just after I'd moved to another job. So slightly ironic there, but we'll get back to that later. So that's me. So I've been a derm nurse for over 20 years, doing general dermatology, and then I kind of specialised into the assisting with surgery. So here I was with this brand new role. There were no other nurses in my department doing surgery. We had no paperwork to support anything that I did. There was nothing kind of official at all. And it is quite a vulnerable feeling. So I kind of knew I needed to get things in place. So I started off with an audit. Aren't they great for showing up the glaringly obvious most of the time? But it really showed very clearly that all the referrals coming to my list just varied dramatically. You can have people who haven't done surgery themselves referring for all sorts of bits and pieces, asking for the wrong kind of procedure, for the wrong bit of the body. It was just, things weren't signed, the consent wasn't done. And in St. Thomas's, we've got a 2-stage consent process. So the idea is that the patient will speak to the doctor will talk about what surgery needs to be done and why it needs to be done. Then the patient's got time to think about it, so by the time they come to the surgeon, they've had this thinking time and they've got time to ask questions and really get to understand why they're having the surgery and what impact it's going to have on their life. So that was mostly not done at all. Then I also realized that I needed a teaching pack, I needed a standard operating procedure, and my assisting nurses had no support, no proper training, no direction, and there were all sorts of different kind of standards there. We had a lot of good patient information leaflets in place, but they all needed adapting to the hospital new look, so that all needed changing. And post-op wound care was all over the place across St. John's. Now, I knew in the derm surgery and laser unit, we had a very high standard of wound care, and I wanted the rest of St. John's to come up to that standard. So that was my aim. I wanted to standardize surgery, wound care, and teaching across St. John's. So, you know, not a small task at the end of the day. But I thought as the CNS for surgery, I kind of took that on as my role. The consultants weren't particularly interested in writing a standard operating procedure. They want the nurse to do that boring stuff. So I was quite happy to take that on, because at the end of the day, I knew I was going to get the structure and support that I needed, and then anyone coming up behind me, it would all be in place. So this is the referral pathway. It's changed an awful lot over the years. The main things, I was very clear about what I was happy to do and what I wasn't happy to do. We also have the local health authority. Actually, they get charged for whatever surgery we do. We then charge the local health authority, and then our trust gets paid. So I know it's a very different system here, but that's what happens in the UK. And the local health authority do not want to do anything cosmetic, so no skin tags, things like that. So that was all encompassed there. Because a lot of time, doctors were going, oh, we'll just take that off for you, don't worry, the nurse will do that. And we're not going to get paid for those kind of procedures. So having this referral pathway tightened those kind of things up as well. And there are different kind of grades of surgical experience. So we've got kind of new surgeons here, the nurse surgery list, the clinical fellow list, so these are more advanced registrars, and then we've got the consultants list for Mohs micrographic surgery. Sorry, it's a bit fuzzy up there, it's not particularly clear. But so the whole referral pathway made it very clear from administration what lists patients were going to be referred to, depending on what their issues were and how big the surgery was going to be. And it just really tightened everything up. So we demanded that there was going to be consent. I demanded that the histopathology was going to be ordered on our electronic system. There was going to be clear instructions in the notes, and if you know doctor's writing, that isn't always clear. So I wanted it backed up with a clinic letter, because I couldn't read the doctor's writing. And they just made it so much clearer. And with the backing of my consultants, which was also very important, they agreed that if I wasn't happy with my referral, if someone turned up not knowing what was going to happen, and that used to happen, patients would turn up not knowing why they were there, and that should never happen. Our consultant said that I could actually turn the patient away and not treat them. Now, I never did that, but that threat, and with the backing of the consultants, was enough to kind of tighten things up. And it did take a while, and I would throw this information out to all the consultants and registrars every 3 or 4 months to remind them that this is what is expected of every single person referring for surgery in St. John's Institute of Dermatology. So it makes me sound a bit of a control freak, which I probably am, actually. But it meant that the who, what, where, why vouchers, it meant that, you know who was coming, why they were coming, they knew where things were going to be cut out, why they were going to be cut out. And vouchers is for any kind of complex patients who are on pacemakers or on blood thinners or have mobility issues, things like that. That was all kind of in the referral. So once I got this down pat, things started to even out a lot better, and I was not getting these crazy lists with patients turning up with all sorts, inappropriate or appropriate. The next thing was anaesthetic prescribing. Now, I'm not a nurse prescriber. I know a lot of you are, and that's certainly a very good route to go down. It's just not something that I'm personally interested in. I'm a bit lazy that way. So what I wanted was some kind of way of getting the patient anaesthetic prescribed. And at the time, there was a very good process called the Patient Group Directive, which is another UK process, which allows nurses to do a specific drug to a specific type of patient for a specific reason. The nurse would be trained up in that one drug, and then once signed off, you'd be able to give that one drug to that one type of patient in that one type of clinic. Perfect. I thought, this is the way forward. I'll get a patient group directive together. Unfortunately, the lady who I was dealing with in pharmacy, she happened to be the national editor of the Patient Group Directive Committee. And she disagreed with me and said, unfortunately, the Patient Group Directive was designed for unpatient named lists. Now, what she meant by that was something like an example for A&E. You have no idea who's going to come through the door. So a nurse in A&E could have a patient group directive for anaesthetic because any patient that came through the door that you didn't know ahead of time that needed anaesthetic, that could be the right patient in the right time for the right reason. However, my lists, all my patients were booked beforehand, and we knew why they were there and we knew their names. Therefore, it was inappropriate in her eyes, or for the patient group directive group. So I had to come another route, still being lazy, still defying not to be a nurse prescriber. So it's my own fault, really. I worked with the pharmacy department to come up with a document that was very clear about where the doctor was going to sign, what surgery was going to happen. And again, this has evolved over time. We didn't start off with the map there, but I think that's a very good development since I've left the post. But we've got a portion here where the doctor signs, and it turned out to be a really good sheet, and the doctors actually use their own version now as well. It's identical to this, but without the prescribing bit. It's very easy to see in the notes because we're not electronic yet, and it's a very clear tick box, quick, easy document to use. And basically, I know all my patients ahead of time, so I can get doctors to sign the prescription at the beginning of the list, and then I can just pile through. It's also something that can be easily audited, which is always very important, so you can see over time if people are using it properly. The next big thing was a standard operating procedure. As I mentioned before, there was just nothing there. And I wanted a document that covered every single responsibility within St. John's. So anybody that had anything to do with a patient having a biopsy needed to be documented and directed by this patient group directive. And that meant from administration, knowing what codes and what lists to book patients on, where is the histopathology pots, where are they stored, what fridge. And so basic things like that. I sent it all out. I made a kind of a vague outline of what I wanted in this document, and I sent it to various consultants, to histopathologists, and asked for their opinions if there's anything they wanted to add. A lot of the time, nobody answered back, but if it was very important, some people would answer back. And there was one example would be a scarring alopecia protocol. We had a histopathologist who was getting fed up getting biopsies from the wrong bit of the scalp, wrong bit of the alopecia, and she couldn't give any answers to the patients because the answers weren't in the bit of skin that was taken. So she came up with a really clear protocol about to do, you know, with the scarring alopecia. So that made it a lot easier. So we had a lot more answers for those patients, which improved that service dramatically. It needed to be robust. It needed to apply to everyone. So nurses, medical, clerical, healthcare assistants, anybody who's involved, booking appointments, performing, the whole kit and caboodle. And the whole point of it was to standardize the care, improve the efficiency, and maintain patient safety throughout. And it protected staff as well as the patient. It was something that could be audited, and it was something that we could add other documents from the trust to support our documents. So the infection control policy could be added to support this document. And it just added to the gravitas of it. Was it perfect when I first wrote it? Absolutely not. It's changed and developed over the years, as it should do, with other people coming on behind me. They have to make it their own, and as things like the WHO checklist came in, we have to add things like that to it. So it's an evolving piece of work. And that's just the main kind of ingredients, example of. So we, all the time I was being asked to support staff with teaching people how to do biopsies. And again, it was all quite ad hoc. We had a vague teaching pack, but it hadn't been ratified. And because my predecessor just kept getting pregnant 4 in a row, so she didn't come back to her role. So she did manage to get it ratified, but then the trust changed how they wanted things to look. So I had to rejig everything. But I used her skeleton to form the teaching pack. And it just kind of went through all the basic techniques, through anesthetic, how to prepare the theatre, but it also outlined jobs like the assisting nurse, people like that, how to maintain the theatre, how to set up a trolley, all the basic stuffs. But it meant that at the end of the day, someone could turn up and be given this pack, and it would support their learning, and they would know what their responsibilities were. And the same with the standard operating procedure. If we had a new registrar come into the department, we were able to give them that SOP, and they could look at that, and they would know exactly what everything was, what the responsibilities were, and who they had to report to, the whole process. So it made life a lot easier for everybody, I hope. Anyway, thanks, Emma. So it is very much an enhanced role. And in the UK, things are still changing and moving. We still haven't quite got it right. It's no national standards. There are lots of different courses going on around the UK. There are some university courses that take quite a long time to get through, and adds to your masters, for example, points towards your masters. And there are several kind of new 2-day courses. The Nottingham course, unfortunately, has closed down now, but literally last week I discovered there was a new course in Dundee. So there are 3 or 4 different 2-day courses to do with nurse biopsy, but it is definitely out with the normal nursing procedures. And when I went to conferences in the UK, I was talking to other nurses, and there were Band 5 nurses, which in the UK are kind of junior nurses, doing biopsies on their own, unsupported, with perhaps a registrar somewhere in the department, and they felt very vulnerable. So we knew that that was a real issue. And the BDNG have come up with their own guidelines, and that's one of the things they state quite clearly. It has to be a senior nurse with experience, and that's something that we've put into our own guidelines too. So a minimum of, a minimum of 2 years experience, I think, is absolutely vital. Has to be a Band 6 senior nurse, and the training has to be on need, not desire. So a lot of us may want to do biopsy, but unless it's useful for your service and is possible in your department, there's no point. It's something that you need to practice. It's something that you're going to need to do on a regular basis. And if that facility isn't there, there's no point learning how to do biopsy. It has to enhance patient care, benefit the service, improve efficiency. So if you can prove those things, you're in a very good kind kind of position to say that nurse biopsy training is a good thing to do. You have to have agreement from your manager, and you have to have consultant support. I'm kind of gathering, as I put my feelers out here, that that might be an issue in Australia. So I was very, very lucky to have a supportive manager, and very, very lucky to have consultants that understood that, you know, nurses can bring down waiting times, that nurses can improve the efficiency of the service if they're fully supported and trained. As surgery nurses, we have to know our role within the NMC. So the Nursing and Midwifery Council is the UK governing body, and they're very clear about our role within the nurses' code. And any nurse doing biopsies in St. John's has to have, sorry, I keep doing that, finger on the right button, has to have completed a surgical procedures course, undergone a period of in-house training, because obviously 2 days in a biopsy course isn't going to cut the mustard. It's something that's ongoing, and you need to have that support where you're locally trained or in the unit. And you have to have completed our training package, which finally got ratified. And within that, there are competencies that you can get signed off. What is quite good about the training pack is that you can take it either as a whole and work your way through the whole pack, or if you just want to concentrate on punch biopsies, if that's all your service needs, you can take that bit out and just be signed off for that. We don't expect you to go into kind of, you know, large excisions if that's not within your role. So within our particular demands within St. John's is to have a 3-month supervised training to start off with. And it's quite important to have an end date to training, because if people aren't naturally good at it, it can go on and on and on. And I had one patient or one person at the end of 3 months. She just didn't quite get it, and I was not happy to sign her off. So I had to say at the end of 3 months, I'm really sorry. I'm going to have to stop this training because A, there's a pile of people that want your place, and B, I could see I wasn't getting anywhere with her. And it may have been my teaching style, whatever, but at the end of the 3 months, I just couldn't sign her off in all faith. But the majority of the people I did. And with excisions, you have a bit longer time. People can get it before then. You know, some people are quicker learners than others, so you can learn it before that length of time, but that's the kind of the limit of the teaching process. You have to have access to regular surgery lists. If you don't use it, you lose it, and there's nothing truer than that with minor surgery. These last few bits and pieces are kind of have been added on as time's gone by now, as I looked at the document just before I came over. And that if you're not doing regular surgery, after 6 months, you have to kind of be reassessed. And if you're new to St. John's and you've done surgery training elsewhere, you have to have written proof that you've done it, and they have to be assessed as competent, obviously. This is also something that's a new development within our guidelines. The nurses now are doing directly observed procedures, and they're doing 4 per year, so pretty much on most, you know, a shave, a snip, punch, excision. Registrars in their training only have to do kind of 4 DOPs throughout the whole of their training, so nurses are doing 4 DOPs every single year. So our standards are definitely higher. And they've now asked their nurses to have a surgical appraisal every year with their clinical supervisor, and keeping up to date with national guidelines, obviously. And this is a very good advancement, I think, is to keep your own kind of portfolio and logbook of all the patients that you've done, so you can audit your care. Are you taking the right amount of skin around whatever lesion? Are you cutting things too fine? Do you have a good infection control rate? And these are all good things to kind of keep nurses to maintaining standards. This is just an example of one of the competency documents that we have. And I'll be happy to give you an example of that. I'll send the the team here any documents that they wish. So, you know, there's no point reinventing the wheel if somebody's already done it, really, is it? So, again, is it perfect? No. Is it specifically suited to what happens in the UK? Yes, but it's good to have something to adapt for your own particular needs. This is something that I think is just not focused on enough, certainly not in the UK. I'm not quite sure what it's like here. But a lot of nurses or people who assist with minor surgery in the UK are unqualified healthcare assistants. And especially for biopsies, oh, it's just a biopsy, it's not going to matter. So a lot of these healthcare assistants don't really get good training, they don't really get good support, there's no structured training. And they're quite often dealing with things that are outside of their sphere of influence or knowledge or training. And I felt, you know, very badly for these healthcare assistants. They were under-supported and under-trained. So I knew that was something that I needed to change. A, because I just, you know, if someone was going to assist me, I want them to be of a certain standard. I want them to know what they were talking about and that they were going to give the same good care to all the patients and all the doctors or surgeons that they were assisting. And that certainly wasn't the case when I first started. But unless you support and train people, how are they going to know? So for me, they are, as I said at the bottom, quite possibly one of the most important people in the room. They are the continuity with surgery. Surgeons kind of come and go. Nurse specialists will come and go in and out of the room, but it's those healthcare assistants that help to maintain the theatre space that are the thread running through the whole thing. So greatly underestimated. So me being me, had to come up with another document. So it was a training pack. This was only ratified within St. John's. So the Trust were very clear that they didn't want all healthcare assistants across Guy's and St. Thomas's to feel that they had to do assisting with surgery. So it was just for healthcare assistants in St. John's Institute of Dermatology. And it went right back to the basics, how to say hello to a patient, making eye contact. Because basic things like that weren't happening. You know, people coming into the room and sit down, there's your pretty coat. And that doesn't give anyone any confidence as a patient coming into the room. So it went right back to basics, broke every single job down into its constituent parts. And we had practical training sessions where I would, for example, I would set up a theatre and there'd be lots of things wrong. So that the sharps box would be overfull and there'd be pretend blood on the floor and things like that. And we'd have to bring them into the room so they could spot what wasn't quite right with the room. So little practical exercises just to kind of get the idea of infection control and responsibilities like that under their belt. Also, I did a kind of a basic wound care document. Again, a lot of the healthcare assistants would be asking to do things that, again, were just too advanced, and it's unfair if, you know, if you're not being trained, and you're certainly not being paid enough to do those complex wounds. So any kind of flaps or purse string sutures, anything that needed packing, I thought they definitely need a nurse close by to teach them and support them through those kind of complex wounds. So after all that, and this took several years and things kind of were developed alongside each other, I started on the nurse biopsy course. Did I do it alone? Absolutely not. We always ride on the shoulders of others, and if I hadn't had fantastic training from my predecessor, Emma, you know, she taught me how to teach, she taught me how to approach patients. So from that little nugget of inspiration, everything else blossomed. So there are lots of ingredients that you need to start off a biopsy course. And as I was doing so much teaching all the time, I was getting pretty exhausting. So if I wasn't teaching someone how to do surgery, I was teaching someone how to assist with surgery. And it's difficult to try and do surgery on a patient and be responsible for the whole room and all the other jobs that someone who is assisting you is supposed to be doing. So I ended up doing everything. So I thought, something needs to stop here. I need to develop something where we can actually train people properly, and so I can actually have a bit of breathing space and just enjoy doing surgery. So the guidelines and SOPs, tick, we've done that. I had those in place. Again, I had good support from nursing management, and I had very good support from consultants. And I have to stress, without that trio of ingredients, it's very difficult to get started. I also needed kind of funding, sponsoring for either ingredients. Might have to rent somewhere, so all the biopsy packs that people were going to use, so all the bits and pieces that you needed, catering. I had no idea where I was going to get that funding from. I also we were going to charge nurses for this, so I had no idea how we were going to charge nurses and accept money and where was that money going to go, how I was going to advertise the course and let people know that we actually existed. Again, the internet wasn't quite hugely used at that time, and there was only one real kind of route, and that was through the BDNG kind of magazine. And I needed an appropriate setting, and at the end of the day, basically, I needed help. I couldn't do this by myself. So along comes we've got a nurse consultant, and she was one of the first nurse consultants in Guy's and St Thomas's Hospital. And she's been a great advocate of anyone kind of developing themselves and pushing themselves further. And she said, come on, Tanya, let's get this course on the road. I said, well, I need admin. And she said, it's okay, I've got an administrator. So luckily, I was able to use wonderful Jamie as the administrator. And Karina had access to all the sponsors because she was quite high up in the BDNG at the time, so she knew who to plug for money into Sweet Talk. Jamie did all the boring things that I just was not interested in. He had to set up a kind of a bank code, all those kind of things. And so it left everything else to me. So I decided what the course content was. I was the one that sourced the teachers, because you don't want everything just from me, obviously. The equipment list, finding a venue, coming together with some kind of course workbook. And I called in an awful lot of favours at that time. So that was another thing, working quite a while in the surgery unit. You did a lot of favours for people, and now it was payback time, which is good. Having done the Nottingham course, attended the Nottingham nurse biopsy course, I'd also attended the derm surgeon biopsy course aimed at doctors and registrars. I had a good idea of what I wanted in a course. There were things that I agreed with, things that I didn't agree with. So I needed to kind of make sure that my course was slightly different and that fitted in the way that I wanted it to be. And one of the main things for me was to have a low number of students and a high number of circulating, supporting surgeons. Because any course that I had attended, there would be a huge room of people and just 2 or 3 circulators. And it's very boring for people who were slightly quicker or had a bit more experience. And it was very frustrating for those who were brand new at biopsies and needed that bit more support. And they kind of would miss out quite a lot of the time. So that's one of the main things that I knew would be different, that high ratio. And I wanted it available to doctors and nurses. We've only had a few doctors take up the course, but I wanted it a bit available to everybody. And there was a really good skill mix of doctors and nurses teaching amongst the whole course. And if it hadn't been for Karina, I would have carried on the preparatory phase for quite a while. I'm a bit of a procrastinator. And basically, Karina had to go, right, 4 months' time, we're going to be doing this course. So we had to have a target, and so we could aim towards that, scary though it was. So this is the basic program overview, and it's not much different from any of the other courses that I'd attended. One thing I did add was the medico-legal aspects of surgery that hadn't really been touched on in any other course that I'd attended. And it's the basic theory that we have a morning session and an afternoon session to break things up. We have the theory session in the morning, the practical session in the afternoon. Basic practical skills on the first day and more advanced practical skills on the second day. What I also thought was very important was getting histopathology in there. I mean, there's no point sending off a sample that's crushed or there's not enough information there. The whole point is that the patient gets an answer to their condition so we can actually treat them or cure them. That's the whole point of a biopsy or excision. And so understanding the route, the journey of the specimen, I thought was very important. I've got a fantastic histopathologist who is very good at talking about that side of things. Proper anatomy and physiology, I think, is important. Do I know all the names of all the arteries and nerves in the face? No, I don't. But I've got a very good idea where they are. I know where to avoid. I know where the danger zones are. So I don't have to be an absolute expert, but you have a good idea of where things are. Also, being a slight control freak that I wanted to be very clear about what I wanted to be included in every lesson. So anybody that taught on my course, I gave them a lesson outline. So I would ask them to teach a certain subject, and I would give them the outline of that subject that I wanted them to teach. They could kind of pad things out within that, but I wanted an overall view of the way things were going. I wanted them to understand what level to pitch things at, so nobody got left behind. I think it kind of gave everything a good kind of, it gave the teachers a good idea into what direction to aim things. And so there it was. We started our biopsy course, and within that we managed to get the British dermatology surgeon's workbook, teaching pack within our workbook. And we decided to do that because our teaching pack within St. John's was just designed for St. John's, whereas the major surgical teaching pack was a nationwide thing, as all the doctors understood it. It was a very high standard, and it had lots of advanced procedures in there as well. And it's always important to have, even though, perhaps nurses might not want to do rotations and flaps, but it's good to know the theory behind them, and it's good to have something to aim for if that's what you want. I'm a great believer in not kind of restricting people. There are lots of things that I'm happy to do and not happy to do, and there are lots of nurses that are doing far fancier stuff than I ever did. But you have to be really clear about what you're happy to do and stick to your guns, because you will be pushed to do more and more and more. So that was the first day, and this is what it looked like. So we had one little room, everything happened all in the same room. But we did have a kind of basic overhead projector, small group of students, and plenty of supporting staff when it came to practicalities. So it wasn't perfect, but it was a good start-up, and we got very good feedback from those that attended. Was it petrifying? Absolutely. Have things changed over time? Most definitely. But you've got to start somewhere, right? This is where we are now, so it's slightly different. So we're over at the Guy's site now, and we've got this amazing Museum of Pathology as part of Guy's and King's College University. So it's an extraordinary setting in which to set the biopsy course, so that's a bit of a selling point as well. It's wall-to-wall specimens of all parts of the body. It's got a dedicated lecture theatre. It's got other open spaces where you can have kind of the catering and more casual seating areas. You can have little breakout areas for wound care, bits and pieces like that. So it's absolutely fantastic to have this at our disposal. And there's also a kind of a museum tour if you want, because the guy who runs the place is very passionate about all his specimens. The practical sessions are run in specific labs now, so it's much more professional and higher standard. And we've got lab staff who can store the pork bellies properly, because we had one year where they were still frozen when we tried to do biopsy, and I kid you not, we were microwaving them before they were going out. So some of them were partially cooked, which, so don't do that. If I get them frozen, by all means, but make sure they're defrosted the night before, leave them out. And things like, sharps containers and infection control things, all is on hand. The other thing is everything is kind of developing even further now, because I no longer run the course, although I'm still teaching on it. Things have developed, especially with COVID, all the advancements in video training and teaching, and so they're now incorporating more and more of that on the course. So A lot of the ingredients that I had in the very first place have been taken out and moved around or put on video. I think that's fantastic. They're taking the opportunity to develop the course even further. And there's going to be further courses available on the St John's Derm Academy that are going to be free and available to anybody. So if you all want to access those, you're most welcome. They have increased the amount of pupils to 30, but we still kept the ratio of circulating staff to a very high level. So this is the team from last year. This is at the end of the day, and a lot of the medical staff had kind of moved off to carry on with clinics and what have you. So things look very different from the first day. These are the practical labs that we have now. So you can see it's of a much higher standard. It's much easier to maintain, much clearer. And we've got all these wonderful kind of screens all over the place. So even if there's always a screen right next to people, so they can have a good look, unless I get my head in the way, which does happen quite often, unfortunately. So it's come a long way. But this is over a period of 9-10 years now. When I left that particular role, I carried on doing the biopsy course for another 2 years in my new role. And then those surgeons that took over from me, we lost our administration support, and they weren't happy to carry on with the biopsy course without administration support, which I understand. So we had 2 years where we lost the course, but then things have carried on, got back into the swing of things with proper support. So here are the 3 nurse surgeons here. So we've got Sergey. He is a fantastic surgeon. We've got Rosalind, and we've got Maria. So these are 3 people now that are carrying on the nurse training after I've gone. A fabulous job they're doing too. They are very happy to share any information that you need. So if you want copies of any competencies, any guidelines, any SOPs, please feel free to contact any of them. They've given me permission to share their emails with you. So if you want that information, just to kind of give you a framework to start things. And Karina, who's head of the St John's Derm Academy, or the nursing part of it, is also very happy to be approached. She's a fabulous trainer and teacher, and very supportive to further nurses' teaching. So, and that's pretty much it for the theory session. Is there any questions? Is there anything that is a bit strange, didn't sit right? Anything you want to ask questions about? Yep.
I work in private practice. I don't know whether or not my June would let you do that, but anyway, that's another mindful. But all that insurance and the legalities of what we're doing, that would worry me, because we're all very litigious these days.
Yeah.
So I don't know whether or not we covered that.
I didn't, because it's slightly different in the UK.
Right.
I do understand it would be a much bigger and more complex problem for you guys over here. We are essentially covered by the trust. So that was another reason for getting the standard operating procedures and guidelines in place. So as soon as it's ratified by the trust, then we're covered under their insurance and supported by them.
I think we are covered under the doctor's insurance.
We are, but if we were doing anything outside our scope.
No, as long as you're trained and competently trained, and you are signed off by your consultant, because then you can cover those duties. You can follow through, suturing, whatever, as long as you're had that sign off for 3 competencies and worked under him or her for a certain period of time, which I think it would be the same, something like 3 months. But this is all what we're trying to do now with ACD, to be under their umbrella, to follow through with something like what Tammy's talking about. This is our direction and goal as well. But then you'd be totally covered, as Tammy's saying, under the Doom College. And that's what we're hoping to do.
I mean, getting things standardised nationally is a real problem. It's the same in the UK. We've got all these little derm courses, and they're doing the same kind of things. And we now have the BDNG with their guidelines, but it is still vulnerable to going back to your local area and being supported by a consultant, and depending on how well they support you and how much access you've got to a biopsy list, and their further training for you. So standards are very different across the UK, and that is a bit of a problem that's kind of been raised. A lot of doctors, that's one of their things they're against nurses doing biopsies, is that the standards vary, but that's up to them.
So going back to what Loretta was saying,
Yeah.
saying about what will protect us, unless you're a member of the union and have professional indemnity, what will happen to us if our consultant isn't happy with our performance? So, example, plastic surgeon goes away or a dermatologist goes away on leave and you're responsible for patients, even though you are their employee, what's to stop them from disagreeing about the treatment that you've... So there needs to be some form of protection for us against who we work for.
Yeah, absolutely. One of the things that I put in our standard operating procedure was that there has to be a medical person on site in the department, not, you know, at the other end of the ward, a few corridors away. You may never talk to them, you may not actually need them, but they have to be there, and if there isn't any medical cover, the list gets stopped.
So just a quick question as well, with the biopsy, what you do biopsy, is the doctor the one who tells you what's a biopsy and then you biopsy, or is that your own clinical, use your own clinical judgment?
That's a good question, because that changed over time as I got more and more experience. So the question was, does the doctor tell you exactly what kind of biopsy to do, or is that a nursing decision? And that, like I say, changed over time. When I very first started, it was very prescriptive. But then I realised that, you know, sometimes those referring to me had less experience than I did, and they were asking for the wrong thing. So as my experience grew, if I disagreed with the referral, and that was another reason for having someone medical on site, I would then go to the doctor and go, I don't think this is the right procedure. Do you agree with me? And they would either agree with me or disagree with me, but we would have a conversation about it. And if we decided to change the referral, then the doctor would write in the notes, we're changing it to this procedure because we want this particular outcome. So that did change over time, and as you know, the more experienced you are, the more mouthy, confident I got.
Are all your procedures done in theatre?
Yeah. Well, you know, they did try and start having biopsies in kind of cubby holes, and literally, you know, there'd be a desk and a bed and no space to put the trolley. And when I said, what happens if a patient has a crash or there needs other support, where's that trolley going to... And they didn't have any answer for that. So again, that was another thing that I put in the SOP, that there has to be a theatre space, a dedicated theatre space that isn't used as a stock cupboard or a storeroom, or that is constantly ready for action. So again, that's another thing we added over time.
Excuse me.
Like, how advanced are the excisions that you end up doing?
For me, I didn't like doing excisions on the face, head and neck, hands and feet and wrists and ankles. They are very tricky places and a lot can go wrong. I've seen consultants kind of accidentally cut through nerves and suddenly the patient doesn't have access to their thumb movement anymore. So that used to petrify me. Being scared is not a problem with surgery. It kind of keeps it quite clear. But I can do, I was doing biopsies anywhere on the body, including genitalia, face, head, neck, anywhere. Excisions only on the body, and I was doing quite large ones by the end. But anything that could have direct closure, I was happy to do. Anything that involved a rotation or a flap, that's beyond my pay scale. But when I did the referral guidelines, I kind of made it slightly stricter. So I was doing things outside of that, but I wanted to support anybody coming up behind me to have kind of that rigid, so they could say no if they felt uncomfortable. So I was very clear about what nurses and the size of things that they were allowed to do. And as over time they got more experienced, you can You certainly stretch that, and unless you stretch yourself, you don't develop. But you've got to have that support there.
Did you always have an assistant?
I wish. You know, that's the ideal. That's what I want. It's not always happened, and I'd rather just kind of get on and do it rather than wait for somebody to be around. I would say 98% of the time, yes. And sometimes, you know, the assistant is less than assisting, so you might as well just do it yourself anyway. So, yeah, so it becomes tricky over time. But the idea is absolutely yes.
A question
Can I just give you this one?
Financial sustainability. I'm actually a nurse practitioner in a hospital and I do punch biopsies. And it's in a clinic space with a trolley. It's, you know, we're seeing a patient, they've got a lesion that looks suspicious that might have, you know, they might have large cell transformation in their disease or something, and I can do that. And obviously I'm working with a team and have access to, you know, dermatologists and registrars and everything. But set aside from that, the financial sustainability, even for nurse practitioners, both publicly and privately, when we see patients, there's actually not that much money attached to patients seeing a nurse practitioner compared to seeing like a dermatologist or something like that. And that sort of carries down to like biopsies and stuff, and even within a hospital, it's really hard to try and convince people that, because these are amazing models and they have such, you know, like your teams have done so much for so many patients, but when it comes down to people showing the finances, they're like, well, we know we can get the regs and the consultants to do that work and we're going to get money for that, versus you as the nurses have done extra training in that, but we're not going to get any money to bring that back into the hospital. So that's kind of like the stumbling point at the moment, even though we know that, you know, everyone's working within their scopes and working as a team, and that's why kind of things are like not wheel spinning, but it's a bit tricky sometimes. Yeah.
And I suppose patient satisfaction doesn't bring in money, does it?
No.
And that's
well, but actually it keeps people out of hospital.
That comes back to ethics too,
Yeah.
I think, that why should we not be paid the same as, you know, because if you're still going to charge the government or the patient or the private health insurance, but the surgeon still gets paid the same as whether he did it or not, you still get paid whether you do it or not.
But then I think your qualifications or competencies, you would want different levels of payment.
That's what I'm saying, yeah, like you would really have to be.
With your classification, and that's what we sort of want.
Do you want that on an hour, like nurses are constantly on an hourly rate a lot of the time,
That's
where
what they are.
they should be on a theatre then rate, do you know what I mean? Because if one day I do 5 biopsies and the next day I do 5 excisions, why should I be paid the same for doing 5 biopsies as I would for excisions and then 5 wound cares the next day?
It's not under the umbrella of the government.
Yeah, but like my surgeon that I work for, he's going away for 2 weeks, so he'll always put on an extra couple of lists to catch up on that theatre. You know, they're driving around in Aston Martin and blah, 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 they've got Subarus and stuff, you know. It's kind of like, why should I risk my career? Because, you know, things go wrong.
Yeah.
You've got to be comfortable.
Yeah.
You want to do something, you say no.
No, it's not that we don't want to do it, but it's also, why should we help take the load off? Yeah, it's great that we're getting more skilled, but not get paid for
Yeah.
it. Because then we'll go reflect back on the doctors later. Because if we end up staying on that, then it's like, well, what's the point in paying, you know, training a doctor to go through all their surgical training that they've done to do these surgeries? That's why they get paid so much. Government are going to go, let's cut that funding there and just put the funding towards nurses. And then, you know what I mean?
You do, but that's the whole thing. You need to be knowledge. So to be knowledge and the doctors to understand what it's capable of, and if you want to do certain courses and if they're happy with that sort of thing, then you start to get recognised You need to be one speciality and to be recognised and acknowledged. And I think without that, we're not going to go anywhere.
Yeah.
You're not even going to get levels of partying. We're such a huge area of private practice. We have got something like UK's America and that boards, and they have huge funding. We're a private practice, you know, we're private. And our association is not for profit. But you need money behind you to train. Things cost. Our postgraduate course was 60,000. That didn't have that. But we got help with sponsorship. So it's all the little steps. But, you know, you've just got to keep, you know, going and trying to achieve and have a goal at the end of the line. And the goal is to make us a specialty. And then you get recognition. But we've got to get recognition within the industry.
Yeah.
You know, until they acknowledge us.
But it's not the biopsies and things so much that worry you, it's more like excisions and things like that. I mean,
Things you get bored with biopsies very quickly.
anywhere to travel, train all around the world, you know, and then I come in going, hey, I can do like a 6-month course and I can do decisions. It's just really not good. You know, like, that feels like we're not recognising them as well. A lot of the problem is the government is not trained enough for burns as well. And that's very clinical. And then we will be those patients as well, that, and our children that won't be able to access.
But I think you can't get signed off unless you're
And look at America and stuff like those countries where you don't have private health insurance, you don't see it.
Mm.
We want to be there one day.
Can I just ask, sorry, a question on your, the nurse practitioner thing you were saying, is I think Medicare, I'm a TNP
Yeah.
in the hospital.
Yeah.
And basically what it will probably come down to is whether Medicare is willing to reimburse you as a nurse practitioner.
Yeah.
I think it's a bit separate to the private, but if you're working in a hospital, if you can prove to the hospital that you're worth that money, and if not, you need to show them that it reduces the wait list, maybe for the doctor, so they can start doing bigger.
Yeah, it's got to do with the public-private, like because we are a public hospital, but it's that whole like you can't, you know, put into Medicare to get money back because it's seen as double dipping, even though you're, but actually, yeah,
I think from a financial thing, for us here in Australia, that is a tricky
yeah.
standpoint.
And
I
I
certainly
certainly
think from
come
a,
after you, if you work in a private practice, something goes wrong, they end up with major problems in the public system. Is
But I-
then the ACC, all those things are going to then
everybody after you. Yeah, but I suppose in terms of the skill, learning how to do it and finding where your niche is within your area, and if you can reduce wait times by learning to start by doing punch biopsies,
You
small
can,
incision
but
shapes,
then the hospitals still say, you know,
How you get the money,
they
yeah.
say, well, you know, even if we agree to, you know, your right to private practice, which some of us currently have in our facility, you know, it's $8. They're like versus some, you know, the consultant or the reg or the consultant is
I
more.
think
They're like
the way
that's
that we
where-
get around it is that everyone gets tipped by seeing a consultant. So if you're running a clinic at the
Yeah.
same time as a consultant, and this again is
Yeah,
just
that
finances,
because I've
which
wondered,
is important.
we have kind of thought that that must be the
If you
way.
run
Yeah,
side by side clinics and that consultant is there and happy to be a part of your practice, and you tick that they're the consultant on for the day, but you're the one doing it, you can get that money.
yeah,
So that's how, I mean, that's how it certainly works for all, I'm sure anyway, so the registrars all work under it. If they get tipped, if they're a doctor, a nurse and a consultant, and then you get the money for all of it.
Yeah.
So it might just be tweaking your system so that you can use your skills and stuff like that. But I
well, we
certainly think as far
we
as
do use our skills, but we basically just it doesn't
money
get it.
perspective doesn't translate.
It was kind of like just it was too tricky at that point in time. But
I mean, in the UK, we don't get anything. You know, we perhaps get a higher grade, but you know, I'm doing a lot of what I used to do. A lot of what the registrars were doing, and quite often a lot better than the newer registrars. Was I getting any more? No. And we were certainly a cheaper version. That was one of the selling points for nurses to do it in the UK. We were definitely cheaper than the doctors, which is perhaps not the best way to go, but that was an in.
But if it's not your practice, you don't have the sterilising to pay for. You don't have the packaging, the instruments, all that goes with it. You're not responsible for, but you're just doing the biopsy. So for me, why would I want any extra money?
Yeah.
I don't have any overheads, so.
It has to be a personal decision, isn't it?
Yeah.
I think you might have just answered my question. I just wanted to ask, in the UK, did your award wages go up for your nurses that were doing this? So the award rate didn't change?
No, I didn't get
depending
anything
on their
extra for
skill
doing it,
set and
other
their
than the thrill of
qualifications.
doing the surgery.
Yeah.
There is one nurse consultant that I'm aware of who is a nurse consultant in surgery, and she started off working very closely with a plastic surgeon. And so she does flaps and grafts. And there's one other chap that I was aware of as a nurse was doing Mohs surgery. Now, you know, he may have been a band 7 or a band 8, which is nurse consultant, but even then, you still don't get paid enough to do Mohs surgery as a nurse. I wouldn't want. No.
It's like an extra course after dinner.
Yeah. I mean, it's, that was completely out with my idea. But so they're the only 2 examples that I'm aware of in the UK where they're a slightly higher grade. Everyone else is a band 7 or band 6.
I think that might have been, is that sort of the point you were trying to make, that, we increase our skill set, but our award wage doesn't reflect that if that's not being increased to remunerate that?
So, when something starts, it sort of increases itself.
Okay, well, one last question from the back there.
My last comment was just that I think what you recognise in the UK and Australia is that in the UK, a nurse practitioner is not a protected title. So if for myself, I'm not working as a nurse. But if we can expand the practice, that's what is being paid for, that's the way you would think about it.
I was just saying that the difference in the UK and Australia is that nurse practitioner is not a protected title. So in Australia, nurse practitioner is the highest clinical position you can get. So if you're talking about wages and increasing skill set, maybe that's the way in Australia we need to think about it.
Okay, we've got about 10 minutes left. Is there anything burning practically that you wanted me to have a look at or show you? Will I be teaching you to suck eggs? One of my big bugbears is anaesthetic infiltration. When I hear a registrar going, it'll hurt a bit, but the pain will go quickly, it drives me nuts. It shouldn't be painful. If you anaesthetise correctly, slowly, you warm up the anaesthetic, you talk to the patient. We add sodium bicarbonate to our adrenaline also as a buffer. So all those things, and if you do it correctly, obviously there are some places where it is going to be painful. The fingertips, the nose tips are always going to be painful, genitalia. But on the whole, I'm not scraping my patients off the ceiling with the anaesthetic. But pretty much every doctor that I watch do surgery and anaesthetic, the patient knuckle are white. So is that something you come across too? We have a 20 ml bottle of anaesthetic with adrenaline, and we use 2 ml of Sodabic, which is 0.9%. Yeah. And it makes a huge difference. But if you don't have that, just going slowly, warming it up to room temperature, all those things, going deep first, coming back and going up. Doing the anaesthetic where people just go in every single angle drives me nuts. Drives me nuts. Yes, I won't do that example, but yes, that does come back to me. So was there anything that you wanted me to practically do? We've got this lovely bit of pork belly here, just waiting to be biopsied, bought at great expense with huge trouble and form filling and all sorts to get it in position. Yeah? What do you want me to do? Anything. Well, you're not going to be able to see it from there, so the only way you're going to be able to see anything is if you come on up. And the table's quite tall, so...
Do you want to stand up there?
Are people actually going to see anything? Oh!
Because
Okie doke. What else have I lost here?
Do you want the chairs over to you?
I'll just grab
Is that
one.
easier?
Do you guys use skin hooks over here?
Yeah.
You do? Fantastic. Trying to get registrars to use skin hooks is just nigh on impossible. We are just kind of... That's a bit better. That's all right, I can work with this. So it's getting those all-important deep dermal sutures that's the tricky thing. And getting the eversion is the skill. Whether I'll be able to manage it on this lovely bit of pork skin, I don't know, but we can give it a go. And eversion is so important to kind of support any kind of wound. So if you bring the sides of a wound together directly, things will stretch, especially under pressure, and the scar will stretch. But if you evert it and support it, then when it settles down, it'll be nice and straight. So, and what kind of size blades do you use? Do you use 15 and 10s or just 15s? Do you use 10s on the back? That's nothing. People are just going to get stuck into the one size blade and don't want to stretch out. You know, you've got a size 10 blade for some big chunky men's backs. You can really get a good pile in there. One thing is, was there a marker over there, surgical marker? I need an assistant now. That's a surgical marker, yes, thank you. So always mark your site. I'm sure you always know that, but I had a registrar kind of didn't mark the site, put the anaesthetic in, so the lesion was there, he put the anaesthetic over there, and then wondered why the patient felt pain. And also, you know, lesions kind of disappear under anaesthetic, so unless you circle them, they disappear and you're cutting out the wrong thing, and it's very embarrassing. So, if we've got our lesion there, pigmented lesion in the UK needs to be removed the 2mm margin. So I'll do do you do dog ears here, or do you always do an ellipse excision? You go straight to ellipse. Yeah. If you needed to do dog ears, you could.
Yeah, sometimes we do that.
Cool. So I was always taught in the early days to cut anything out circularly and then do the dog ears, and you end up with a smaller scar at the end of the day because you can control the dog ears. But histopathologists like an ellipse. So I do as I'm told. So we'll give it a go. And I might have to eat my own words here and use the 10 blade. So you use the tip for scoring, and then the belly of the blade for going deeper. And we're trying not to get the crosshatch at the ends, the corners. Can everyone see over there? Or is this... You can come closer. Yeah, I haven't got halitosis, well, I hope I haven't, but... So you've got your dermis, your epidermis and your dermis and your fat layer, and you would do a horizontal across the base of the surgical wound, so you need a full thickness of skin. Obviously, this is quite thick compared to a human being, so you need the full thickness of skin for histopathology. And then you would see the skin tension lines. So in this pig, I've done it obviously in the wrong direction, but in this pig, they should be going across there and up here, kind of in the right direction.
Do you release around the edges at all?
Absolutely, yep. Undermine. And that's another way the skin hook comes quite happily into that. So I use the scissors, so I can lift up the dermis and I can go horizontally in with a pointed end and open up, go in and open up, and then you can get a nice kind of even level. Another way of doing it when you get more confident is to pull back and then just use the blade. And then you can use your finger to see if you've got a nice even level. That's if you're in a hurry, which I kind of am at the moment. So we've pretty much got released all the way around. Last bit there. Where's my suture holder? I definitely had one here earlier on. Right in front of me, thank you very much. So I'm one of those bad people that doesn't use kind of forceps very well. I think most people, once you start surgery, you're taught that way, and then in front of an examiner, that's what I would do. But in real life, you use your fingers just like the doctors do. So again, the skin hook comes in very handy for that. And you can, I've never had a needle stick injury from a skin hook, because you can always feel where the tip of the hook is. And you get your needle. We want the knot to be at the bottom of the wound. So I get the hook just underneath the epidermis, and I can use the blade, the needle, to go right back as far as I can and hook right underneath the epi. So you get a good chunk of, you can just see it coming through the epi there, but you can get a good chunk of the dermis, and that's where all the strength is, and that's what's going to support the wound. If you get these internal sutures right, the top sutures are just there to kind of make things look pretty at the end of the day. All the work happens with these internal sutures. And again, I can avert the other way. I need to make sure I'm going directly opposite that suture where I've come out before, and I can skirt just underneath the epidermis and through the dermis to get a nice chunky bite. And I can use the hook to grab the tip. I need to make sure the tails are both inside of the right side of the loop. Now we're going to see if this works or not. So I want the knot right at the bottom. This probably isn't the strongest suture. And I always say, you know, if that particular suture doesn't work, keep it in there, put another one in. And then you take out the ones at the end of the day that aren't useful. Same if you're stopping anything bleeding. If something's bleeding and I can't really see where the artery is because of the blood flow, I just keep putting a suture in until the blood flow is under control, and then I can see what I'm doing, and then I can put the right suture in the right place and then take out all the unnecessary ones. So suturing has lots of different purposes, not just kind of closing a wound. So this isn't perfect closure so far, so we keep going. And again, hook just underneath the epi, grab a chunk of the dermis. I can feel where that needle's coming through. And float underneath the epidermis the other side, exactly horizontally opposite. I hope I'm not doing anything differently from what you're used to.
Just a different technique, actually.
Is it really?
Yeah, just a different way of different. Yeah, normally ours would go in that side and then out this side, but still in the layer.
But do you manage to keep the knot at the bottom when you do that way?
I'm just saying what the doctors do. They would go in there and then out there, but underneath still. So you're going in that side and then in that side.
Okay.
Yeah, but just a different kind of suturing. That's all.
But that way the knot would be much closer to the surface. And so is at higher risk of coming through, an increased risk of infection and all those. So getting the knot right at the base of the wound, far away from the surface, is definitely a lot easier in order to avoid that. So that one was slightly more successful. So bit by bit, we're reducing the pressure on the wound edge. I should have chosen a more kind of a softer bit of flesh, but
Yeah, all the doctors do it differently, don't they? They all have different techniques. The younger ones seem to be so good at it. I think the older ones are just set in their ways and
well, yeah.
not really.
And we all, always do what we were taught, really. So if we pick up bad habits from whoever teaches us. So you keep rinse and repeat until there's no pressure on that wound edge. And using the whole of the suture and getting as many stitches out of the suture as you possibly can, I always find important because sutures are expensive. So any registrar that gets about 3 stitches out of one suture gets a rocket from me, I can tell you that for nothing.
My boss is, I always say he's Scottish in his last life. He get out suture and something like that.
I did have more internal sutures somewhere, but I'm just going to have to use external sutures. You might be able to see them a bit better as well. So again, we've reduced the pressure on this wound a little bit. And also, if you've got a large needle, I can reduce the size of that needle depending on where I hold it in the arc. So if I hold it towards the end, I've got the full arc of the needle, so it's large. If I want to make this needle smaller, I just hold it closer to the tip, so I have a smaller part of the needle to deal with. So I'm always happy to kind of deal with a larger needle than a tiny needle, because using a tiny needle and getting a decent grip on things is difficult. So I've got much more scope with a larger needle. I don't know how you guys feel about that. So I'm going to have another go at the central suture here. How much time have we got left? The clock ticking away. We're eating into your tea break, and that's just unforgivable, isn't it? This might be slightly easier to see with the so it's sticking out of the epidermis there. Oh, look at that. There you go. It's so satisfying. I don't know why it is. My mother was a quilter, so I think I've got those. And actually, joking aside, I really feel if you are a dressmaker or have done any kind of sewing, you understand that dog ears are darts, and a running locked is kind of a blanket stitch. So I think you've got a head start if you're a bit creative. So it hasn't got the perfect eversion there, but the sides are together with very little pressure. The way I would get eversion is use a mattress suture, and I love a good mattress suture. They're my friends. So you can do the vertical mattress suture or horizontal. What's the preference of everyone here?
Probably horizontal.
Horizontal, yeah. It kind of depends on where the body is and how much pressure you want to kind of remove. Here I'm going to do a vertical one. So I kind of do a near, and then I would go in deeper. You can do it the other way around. You can go deeper and further away.
It can be very tricky to remove them if put in the wrong place.
They do, yeah.
Yeah, my boss now, he'll do them all in dissolvables, just in case we can't get one.
Where would you actually use
Unless it can't be.
a mattress suture? What situation?
A lot on the back.
See, it's gone through the skin. So yes, areas of high pressure, and then you only do them when you absolutely need, and you only kind of came out. Sorry.
I was going to say, how do you see to own
It's magic.
Where is it?
It's invisible. So my hands are in the way, so you can't really see anything.
And look, your hands aren't shaking. That's amazing.
I am on the the inside.
I know. We've got a couple of doctors. I know.
It is petrifying, but it's so satisfying and thrilling. See, now you start to get the aversion, so things just kind of slightly raised up. And you want to pull the knot tight so you get that aversion, but not so tight that the knot is buried in the skin. That's, and that's when people are picking it out and the poor patients.
Sometimes do.
Yeah.
Method,
Yeah, they do it so hard.
You lose it.
That's because they're just not quite sure.
And what do you do if you get those ones that are quite stuck?
You put a bit of anaesthetic in and dig them out.
Pardon?
Put a bit of anaesthetic in and dig them out.
Oh, right.
Or suture spit.
So if I've got the nicer version there's no pressure, then the top stitches would be very simple, and I would do a nice running suture over that to make it look pretty. And then if there's anything else interesting, we'll call it a day there. So I love a running locked on a back, but anywhere else. Do you do running subcuticular on the décolletage? Do you? Oh, brilliant. Again, they're beautiful to do. I just love doing those.
I love taking them out.
Yeah.
Oh, no, I don't take them out in one. I just snip them all out. Just pluck each little one out.
You know, we've got a problem in the UK is that GP nurses quite often take the stitches out and they're only used to kind of interrupted sutures, so anything else. And I had a patient came in for Mohs surgery, and on his, I think it was back, there was this blue line underneath the skin. And I went, how long's that been there? And he had surgery years ago. But the GP nurse had cut the stitch off one end and cut the stitch off the other end and thought that was it. And there was this beautiful blue line. So, no.
Similar with, what's the black?